Bismillahirrahmanirrahim. Today I'm going to discuss about the myositis component of the approach to myopathy. So I have gone through the if the patient present with the muscular weakness and their tendon reflexes are intact. So patient is having along with that patient is having sorry easy fatigability. So we're going to think that the patient is having myasthenia gravis, right? If the patient is having already enlarged muscle, so we're gonna think that the patient is having the congenital muscular dystrophies. And if the patient is having pain along with that, there is muscular weakness and there is tenderness or pain at the rest. So we can think that the patient is having myositis. So let's talk about myositis, right? So obviously there are some drugs, like steroids, like chloroquine, like cocaine, vincristine, and zidovudine. So these drugs are gonna cause the myositis, right? Okay, so let's talk about the including body myositis first, right? Then I'm gonna talk about the second thing is the polymyositis and dermatomyositis. And don't forget that ethyl alcohol is also going to cause the myositis, and we have statins available that these are going to cause the myositis. So let's talk about including body myositis first, right? So let's move on to the next page. Let's see. All right, so so let's talk about myositis. So patient in myositis, patient is going to have the flaccid muscular right weakness, and if we check the deep tendon reflexes, those will be intact, right? So along with that, patient is gonna have the pain at rest, right? Or there will be tenderness if we touch the muscle, right? So this is so first one is called as the inclusion body myositis. So let's talk about inclusion body myositis. So in these patients, if we get the muscle biopsy done, so we can see just say this is a muscle fiber, right? And within that we're going to see the some inclined bodies, right? So these are the some vacuoles, right? And we're going to see some of the inclined bodies that containing the cellular debris, right? Along with that there will be some inflammation, right? And this is going to cause the degeneration of this muscle fiber, right? So inclined body is actually a degenerative disease, right? This is because of the deposition of Alzheimer's protein, right, in the muscles, right? So peak age is 60 years. It starts at the middle age people. This is going to start in middle age people, then its peak age is 60 years. So mostly the distal lower limb muscles are involved, so quadriceps involved in here, and sometimes upper, if we talk about upper limb, so finger flexors and phalangeal muscles are also involved in these patients. So we're going to diagnose this on muscle biopsy, and treatment is the it has poor response to steroids, so there is no specific treatment for this response to steroids, right? So if the patient is coming with the distal muscular weakness, patient is having the lower, especially the lower limb involvement, right? Patient is having difficulty to stand up, right, from the from sitting position. We're gonna think that the patient is having pain at rest, and there is flaccid muscular weakness. So we're gonna think that patient is having including body myositis. After we can diagnose this after muscle biopsy, right? But there is no specific treatment for this disease, right? So let's talk about polymyositis and dermatomyositis. All right, so let's talk about polymyositis and dermatomyositis, right? So let's define that this one. Okay, it is an immune mediated disorder characterized by inflammatory necrosis of skeletal muscles, right, with evidence of regeneration and sometimes along with the skin involvement, right? So when the skin involvement, we're gonna call this as dermatomyositis, right? So this is basically an autoimmune disorder. It has association with HLA-D or 3, and this is a type 3 hypersensitivity reaction. So we have got the 5 variants of this thing, right? Polymyositis and dermatomyositis. So first one is adult polymyositis. The second one is adult dermatomyositis. And the third variant is the childhood dermatomyositis, which occurs in 4 to 10 years. And fourth one is dermatomyositis and polymyositis associated with the malignancy like small cell carcinoma of the lungs, right? And the fifth one is the polymyositis dermatomyositis associated with connective tissue disorder like SLE, and the patient might have the SLE with dermatomyositis. This is called as the overlap syndrome, right? Also known as mixed connective tissue disorder, right? So let's go back and let's see. Okay, so adult myositis and adult dermatomyositis, let's discuss this. Okay, so if we see that in polymyositis, CD8 positive T cells are involved, and in dermatomyositis, CD4 positive T cells are involved. So peak age is 30 to 50 years, and mostly this occurs in females. Female to male ratio is 3 to 1. Okay, so in polymyositis, we will have the patient might have the fever, malaise, and anorexia, right? Along with that, patient is gonna come with the muscular weakness. If we check the reflexes, those will be intact, and patient is gonna complain of the pain at rest, right? And if we touch that muscle, there will be tenderness, right? So this is a feature, very important hallmark feature of polymyositis. Okay, so there will be some extramuscular features, right? There will be some arthritis in these patients. If we check the lungs, so there will be apical lung fibrosis, there will be myocarditis, and there will be Raynaud's phenomena in these patients, right? And if these features are accompanying with the skin involvement, right? So we're gonna, if these features are accompanying with the skin involvement, we're gonna call it as dermatomyositis. So let's see those, what are the skin features we're gonna get in these patients. So first one is the heliotrope rash, right? So this is a purple lilac rash, and purple lilac rash and edematous. We're gonna see the edematous eyelids in these patients, right? So this is called the heliotrope rash. So this will be around the eyes, right, around the eyelids. So if we see the purple lilac rash, and that is edematous, so that this is the heliotrope rash, right? Another thing is the shawl sign. Shawl sign is the, like people wear the shawl, right? So it will be over, rash over the macular rash over the shoulder and the front of the chest, right? Okay, another thing is the very hallmark feature of this thing is the Gorton papules, right? So these are rough red papules over the knuckles, right, plus over the extensor surface of the joints. So this is called as the Gorton papule, right? So for better understanding, you gotta Google the images of heliotrope rash, shawl sign, and Gorton papule, and I hope you'll be able to differentiate it from other skin diseases, right? So another thing is we're gonna get these mechanic hands in these patients. These are the dry, cracked, fissured hand that are mostly in palms and soles. And we can also see the nail fold erythema in these patients, right? All right, so that's about the clinical features of the dermatomyositis and polymyositis. So let's move on to the next page. So what we need to investigate in this patient is the, if we check the hemoglobin level, so it will be decreased because of anemia of chronic disease. If we check the ESR, CRP, this will be raised, and if we check the CPK level, this will be raised in these patients. And on electromyography, we're gonna get the fibrillation potentials, right? So on immunology, if we get the anti-Jo and Jo1 antibodies, right? So we're gonna get the anti-Jo1 antibodies, that is also known as anti-synthetase antibodies, right? Anti-synthetase antibodies, right? So another antibody that is positive in these patients is anti-MI2 antibodies. So investigation of choice is muscle biopsy, and treatment is the steroids. So we're gonna start the, if there are respiratory and pharyngeal muscle involvement, so we need to start the Pulse steroid therapy, that is 1 gram of methylprednisolone per kg, 1 gram of methylprednisolone per day, right? We're gonna start this for 3 days, then we're gonna shift the patient to the oral glucocorticoid, that is prednisolone 1 mg per kg per day, right? So that's the treatment of this. If patient respond to treatment, so well and good. If patient does not respond, so we have to start the methotrexate immunosuppressive agents like methotrexate, cyclosporin, and azathioprine, right? So let's see the case. So if we if let's see a case of mixed connective tissue disorder, right? Overlap syndrome. A 27-year-old female has presented with complaint of fever, arthritis, muscular weakness, right? So there is muscular weakness in these patients and skin eruptions, right? And examination revealed malar rash, discoid rash, and oral ulcers. So this is basically a case of SLE, right? And along with that, patient is having Gordon papule. So the Gordon papule is hallmark feature of dermatomyositis. So for this is a case of mixed connective tissue disorder. For mixed connective tissue disorder or overlap syndrome, investigation of choice is anti-RNP antibodies, right? Alright, so that's all about dermatomyositis and polymyositis and including body myositis. So we're gonna discuss this in dermatology again, right? So that's all for today.